An official journal of the American Academy of Pediatrics. Urinary tract infections in children. Eric Belligan and Michael Burke, Pediatrics in Review 2018. 39. 3 DOI. 10.1542/per. 2017-7. The online version of this article, along with updated information and services, is located on the World Wide Web at http://pets in review, publications, /content/39/1/3. Pediatrics in Review is the official journal of the American Academy of Pediatrics, a monthly publication. It has been published continuously since 1979. Pediatrics in Review is owned, published, and trademarked by the American Academy of Pediatrics, 345 Park Avenue, Itasca, Illinois, 60,143. Copyright 2018 by the American Academy of Pediatrics. All rights reserved. Print 191-9601. American Academy of Pediatrics. Dedicated to the health of all children. Downloaded from http://pets in review, publications, /996-7986 on January 30, 2019. American Urinary Tract Infections in Children. Eric Belligan, MD, Michael Burke, MD, St. Agnes Hospital, Baltimore, MD. Educational gaps, consideration of risk factors for urinary tract infections, UTIs in young children with fever is critical for accurate diagnosis, as well as prevention of overtesting. The use of perineal bags to collect urine from young children should be limited to specific indications in the diagnosis of UTIs. Screening for and managing bowel and bladder dysfunction reduces the risk of UTIs in older children. Objectives. After completing this article, readers should be able to 1. Recognize the risk factors for urinary tract infections, UTIs in children. 2. Review the interpretation of urinalysis and urine cultures. 3. Review antibiotic therapy choices for UTIs. 4. Describe which children need imaging after febrile UTIs. 5. Discuss prevention strategies to discuss with families. Author disclosure. Dr. Belligan has disclosed no financial relationships relevant to this article. Dr. Burke has disclosed that he serves as a section editor for Contemporary Pediatrics, a monthly publication by UBM Medica, and receives a stipend for this activity. This commentary does not contain a discussion of an unapproved/investigative use of a commercial product/device. Abbreviations: American Academy of Pediatrics Colony, forming unit dimethylcapsicinic acid. CFU DMSA. Woman 4 UTI urinary tract infection. Intravenous. Vica volume cystyrithrogram WBC white blood cell. Case study: Charlotte is a 13-month-old girl with a history of 2 febrile urinary tract infections, UTIs 4 and 6 months ago. She had normal renal and bladder ultrasonographic findings 6 months ago. She presents with a fever that began yesterday. She has no other new symptoms. Her 4-year-old brother had a self-limited febrile illness a week ago, which resolved. At examination, she is fussy but consolable and alert. She is non-toxic appearing. Her physical examination findings show tachycardia with a heart rate of 130 beats/minute without murmur. Her respiratory rate is 28 breaths/minute without distress or retractions. Her lungs are clear bilaterally. Her tympanic membranes appear normal. Her abdomen is soft and non-tender. Her general examination findings appear normal without erythema or labial adhesions. Her temperature is 102.5 degrees F, 39.2 degrees C. A bag is placed to collect the urine sample. The urinalysis from the bag sample has 5 to 10 white blood cells WBCs per high power field, a 1+ leukocyte esterase result, and a 1+ ketone result. Should a bag have been placed to collect urine? Does Charlotte have a UTI? How should she be treated at this point? Epidemiology. UTIs are one of the most common bacterial infections in childhood, accounting for 5% to 14% of pediatric emergency department visits. On the prevalence of volume F39 no 1 January 2018 3. Downloaded from http://pets in review, publications, /996-7986 on January 30, 2019. UTIs and their effect on the health of children are substantial throughout childhood, from the neonatal period to late adolescence too. Infants and toddlers cannot localize UTI symptoms, cannot submit spontaneous urine samples, and have other distinct characteristics when compared to children over 24 months of age. Therefore, we will simplify this review of UTIs into 2 age groups: children less than 24 months of age, whom we will define as infants and toddlers in this review, and children 2 years of age and older. Infants and toddlers under 24 months of age. Rough lifespan percent of infants and toddlers who present with fever have a UTI. 1. Race, age, sex, circumcision status in male infants and toddlers, and other factors alter the prevalence. Knowledge of how these risk factors affect the likelihood of UTI in a particular child is critical when assessing whether the child should ultimately undergo urine testing. When considering race, 10% of white febrile infants and toddlers without focal findings to suggest another source of infection will have a UTI, while 2% of black febrile infants and toddlers will have a UTI. 3. When considering sex and age, female febrile infants 12 months of age or less have a 6% to 8% prevalence of UTI, while febrile girls older than 12 months have a prevalence of 2%. The prevalence of UTI in febrile male infants is markedly affected by the circumcision status of the infant. Uncircumcised febrile male infants less than 3 months of age have a 20% risk of UTI, compared with a 2.4% risk in similar but circumcised male infants. In both circumcised and uncircumcised male patients, the prevalence of UTIs decreases with age. For example, circumcised febrile boys older than 12 months have a less than 1% risk of UTI. Additional factors, such as duration of fever, previous history of UTIs, and congenital anomalies of the urinary tract, alter the likelihood of UTI. Children 2 years of age and older, children 2 years of age and older who present with urinary symptoms, dysuria, urinary hesitancy have an overall 8% risk of UTI. However, as an infant, important factors should be considered that modify risk. After 2 years of age, children are more able to report and localize specific symptoms, such as dysuria. The prevalence of UTI in boys 2 years of age and older is low, especially in circumcised boys. Important factors that affect prevalence in this age group include bladder or bowel withholding behaviors, congenital anomalies of the urinary tract, and previous history of UTI. Pathogenesis. UTIs are usually caused when bacteria invade and ascend up the urinary tract from the urethra and into the bladder. Cystitis, a lower UTI, occurs when the infection and inflammatory response are localized to the bladder. Pyelonephritis is an upper UTI in which the bacteria and subsequent inflammatory response further ascend to the ureters and kidneys. Colonic bacteria are typically the culprits. Escherichia coli is the most common bacteria that causes UTIs in all ages, accounting for 54% to 67% of UTIs in children. Klebsiella is 6%, 7%, Proteus 5%, 12%, Enterococcus 3%, 9%, and Pseudomonas 2%, 6% are other. Common causative organisms. 4. Hematogenous spread to the urinary system is a rare cause of UTI that can occur in neonates and children with immunodeficiency. Root B streptococcus, Staphylococcus aureus, Candida, and Salmonella can cause pyelonephritis through the hematogenous route. Mouse models have demonstrated that E. coli attached to the superficial cells of the bladder lining then invade the cells and multiply. These cells are shed in defense, which exposes lower layers of cells for bacterial invasion. These lower layer cells that have bacteria could be the source of recurrent UTIs. Toll-like receptors are an important component of the host defense of UTIs. These toll-like receptors are on the surface of the bladder and activate the host inflammatory response by attracting WBCs to the surface of the bladder. 5. Clinical presentation and estimating risk of UTI. The clinical presentation of UTI varies with age. Infants generally present late in the course of infection because of initial nonspecific signs, such as fever, and the inability to express symptoms or localize pain. Older children can usually localize early symptoms of UTI, such as dysuria or abdominal pain, and therefore present earlier in the clinical course. Infants and toddlers under 24 months of age. Infants and toddlers under 24 months of age who have a UTI most often present with fever. Fever is a common and nonspecific symptom for which clinicians should consider UTI as an etiologic origin, especially when there are no other obvious signs or symptoms to suggest another diagnosis. Obvious signs, such as a new rash, may suggest a viral syndrome. Recent new respiratory symptoms, such as cough and congestion, suggest a respiratory infection. In the absence of other obvious symptoms, clinicians should be vigilant when assessing risk factors because about 7% of febrile infants and toddlers without an obvious source have a UTI. Clinicians should use the American Academy of Pediatrics in Review, downloaded from http://pets in review, publications, /996-7986 on January 30, 2019. Pediatrics AP Clinical Practice Guideline for the diagnosis and management of the initial UTI in febrile infants and children 2 to 24 months of age when assessing risk of UTI in this age group. 6. The risk factors and table from the 2011 AP Clinical Practice Guideline allow the clinician to evaluate the likelihood that a febrile infant has a UTI. The guidelines use both the probability of UTI of up to 2% and up to 2% to allow clinicians to use their judgment in what is considered low risk and therefore to determine which children need to be further tested for UTIs. The probability of UTI increases as the number of risk factors increases. The guidelines allow clinicians to calculate a pretest probability of UTI to make an informed decision. Table 1. Probability of urinary tract infection among febrile infant girls and boys according to number of findings present. Parameter. Girls. Individual risk factors. Probability of urinary tract infection. Boys. 51%. $296. Individual risk factors. Probability of urinary tract infection. 51%. 5,296. Value. White race. Age 12 month. Temperature 2,102.2 degrees F. 39 degrees C. Fever 2. The absence of another source of infection. No. A risk factors present. No more than 1. No. A risk factors present. No more than 2. Non-black race. Temperature 2,102.2 degrees F. 39 degrees C. Fever 224 H. Absence of another source of infection. No. A risk factors present. 4. Circumcised boys. No more than 2. Asterisk. No. A risk factors present. 4. Circumcised boys. No more than 3. For uncircumcised boys. No additional risk factors. For uncircumcised febrile boys, probability of UTI exceeds 1% even with no risk factors other than being uncircumcised, about which children require further evaluation for UTI. Clinicians should also take into account other factors, such as ability to follow up in previous history of UTI, and include the family in the decision making. If the decision is made to forego testing for UTI, follow up is crucial, as risk factors such as severity and duration of fever may change. Risk factors for UTIs in female infants of this age group include white race, age less than 12 months, temperature greater than or equal to 102.2 degrees F. 39 degrees C, in absence of another source of infection. The probability of UTI for male patients is most influenced by circumcision status. In febrile, uncircumcised male infants and toddlers under 24 months of age, the risk of UTI exceeds 1% without any additional risk factors. Ill appearing children who present with nonspecific symptoms such as fever have important additional diagnostic considerations that include bacteremia and sepsis. Appearing children who warrant antibiotics because of the concern for a serious infection, such as sepsis, should be tested for UTI. Urine specimens should be collected for urinalysis and culture because the antibiotics may treat an otherwise unknown UTI, masking the diagnosis from the clinician. Even though antibiotics for sepsis or bacteremia may adequately treat UTI, it is important to establish the diagnosis to determine antibiotic duration and choice, future risk of UTI, and possible preventative measures, as discussed in the management section. Differentiating a lower UTI from an upper tract infection in infants on the basis of signs and symptoms is difficult, but if fever is present, most consider the infant to have upper tract involvement and therefore pyelonephritis. Laboratory values such as procalcitonin and C, reactive protein, 1 increase, have been shown to be helpful in assessing infants for renal involvement during an infection. 7. If further clarification is necessary, a dimethylcapsucinic acid DMSA scan can be performed. In a DMSA scan, DMSA is combined with a radionuclide to image the kidneys by using gamma cameras. The DMSA scan provides the best means of definitively identifying upper UTI but should not be routinely performed because typically, the management will not be altered on the basis of the results and because of radiation exposure related to DMSA. 8. Infants less than 2 months of age are not included in the AP guidelines. UTI should be considered for every febrile infant less than 2 months of age. Clinicians should be vigilant in assessing febrile infants less than 2 months of age for UTIs, even those with obvious respiratory symptoms. Infants in this age group with respiratory symptoms have an appreciable risk of UTI, with one study showing. Volume 39 No. 1 January 2018 5. Downloaded from http://Pets and Review, Publications, by 967986 on January 30, 2019. Respiratory syncytial virus. Positive febrile infants having a UTI risk of 7%. 9 in infants who present with symptoms of bronchiolitis or respiratory syncytial virus. Positive bronchiolitis. One systematic review showed that the risk of UTI was 3.3%. 10. Children 2 years of age and older. In older children, symptoms such as dysuria, urinary frequency, and / or suprapubic discomfort are common with cystitis. These symptoms should prompt testing for UTI. However, when evaluating children for UTI, other diagnoses should be considered. Patients should be evaluated for non-UTI causes of dysuria, such as obstruction, Candida infection, and vulvovaginitis in female patients by compiling a history and performing a physical examination. 11. Dysuria and urinary symptoms, along with more systemic symptoms, such as flank pain, costovertebral pain, abdominal pain, and / fever, are suggestive of upper urinary tract involvement and thus pyelonephritis. However, older children with UTI may present with systemic symptoms without dysuria or urinary symptoms. The differential diagnosis for symptoms of pyelonephritis includes appendicitis, viral gastroenteritis, bacterial enteritis, renal stones, and in the female adolescent, pelvic infections. Diagnosis. Accurately diagnosing UTIs is critical. Establishing the diagnosis is important to be able to treat and resolve the infection with appropriate antibiotics, prevent further ascension of the infection to the kidneys, determine future risk of UTI, and avoid long-term renal disease. However, overtesting and overtreating expose children to painful procedures, unnecessary antibiotics, and worry. Therefore, careful assessment of the diagnostic test results is important. The diagnosis of UTI in children is based on the results of urinalysis and urine culture. 6. Demonstration of both inflammation in the urine WBCs, leukocyte esterase, and bacteria growing in the culture is critical. There are diseases that cause urinary inflammation without bacteria steropuria in the urine. Examples include Kawasaki disease and infections outside the urinary system, such as viral infections or pneumonia. Also, bacteria may be present in the urinary tract without causing inflammation and infection asymptomatic bacteriuria. Compiling a history and performing a physical examination are important in establishing the diagnosis in all ages. Clinicians should screen for conditions that predispose the patient to or mimic UTIs, such as labial adhesions, Candida infection, and vulvovaginitis in female patients. In male patients, an obstructed urinary stream such as dribbling of urine from the urethra may suggest posterior urethral valves or phimosis. Infants and toddlers under 24 months of age. Urine collection. Infants are generally not able to submit a clean, caught, voided specimen. Therefore, catheterization is often performed to collect the urine sample for urinalysis and culture. Urine collection with a bag is also an option with special considerations, but the urine collected should only be analyzed for urinalysis and not culture. Bacteria growing on the skin in the general area and not in the urinary tract to contaminate the bag specimen. When evaluating infants for UTIs, the clinician can review with the family the advantages and disadvantages of urine collection through catheterization or by using a bag, as reviewed in Table 2. In one study, a pediatric emergency department was able to reduce the use of urinary catheterizations by 1/2 in infants and toddlers 6 months to 24 months of age without missing UTIs by obtaining urine from bag specimens that were placed by the nurse early in the visit. 12 patients with Table 2. Advantages and disadvantages of urine collection via bag versus catheterization. Advantages. Catheterization quick urine culture can be sent initially. Bag specimen may prevent the pain and discomfort from catheterization if your analysis findings are normal. Disadvantages pain and discomfort. If your analysis findings are abnormal, increased white blood cell count or leukocyte esterase, then would proceed to catheterization to confirm may take a substantial amount of time for an infant to void in the bag. 6. Pediatrics and Review downloaded from http://Pets and Review, Publications, by 967986 on January 30, 2019. Bag urine specimens with evidence of inflammation moderate or large leukocyte esterase or nitrites underwent catheterization for culture and had antibiotics started while culture results were pending. Suprapubic needle aspiration of urine from the bladder is also an option for obtaining urine specimens, but is less commonly used because the procedure is more painful. The catheterization and the success rate is low, being 53% in one study. 13-14 a newer approach for urine collection in neonates and infants is the bladder stimulation technique. First described in 2013. 15. The technique requires 3 trained providers and involves holding the infant upright while alternating between tapping the bladder and massing in the lower back. During this process, the third clinician waits, waiting to collect the urine specimen midstream into a sterile container. Further studies are required to validate this technique before widespread use. Interpretation of urinalysis results. Once a urinal is obtained, the clinician must interpret the results carefully. Urine dipsticks can be used to analyze the presence of leukocyte esterase, a marker of WBCs, and nitrites, a marker of some gram-negative bacteria. Among other things, however, urine dipsticks cannot be used to detect the concentration of WBCs. Microscopy of the urine allows WBC concentration data to be collected, which, together with leukocyte esterase and nitrite data, improve the sensitivity for UTIs, as shown in Table 3. The nitrite test has poor sensitivity in infants because infants empty their bladders frequently, often before the 4 hours required for gram-negative bacteria to form nitrites. As such, absence of urinary nitrites does not rule out UTI. However, with specificity of 98%, presence of nitrites is highly suggestive of UTI. Generally, 5 or more WBCs per power field or 25 WBCs per microliter is considered pure and increases the likelihood of UTI. 6. Interpretation of the urine culture results. Urine culture results also need to be carefully interpreted. The number of colony forming units CFUs per milliliter, the number and types of species of bacteria identified, and the time lapsed in processing of the urine sample should all be considered. Generally, 50,000 CFU/ml in high rep presents considerable urine bacterial growth and is clinically significant. 6. However, 10,000 to 50,000 CFU/ml may represent UTI, especially in neonates, children with immunodeficiency, children with urinary tract abnormalities, or children already taking antimicrobial therapy. Even if a clinically significant amount of bacteria grows in the urine culture, this does not always represent UTI. Bacterial species, such as coagulase, negative Staphylococcus, and Corynebacterium, are generally non-invasive in healthy children and could be contaminants or bacterial colonizers, not causing infection. Other studies, additional studies, such as blood culture and serum chemistry levels in infants suspected of having a UTI, are sometimes obtained in the initial workup of the fever. Assessing which infants with a UTI also have bacteremia is difficult, and in infants older than 2 months is often not necessary, especially if the infant is well appearing. 16. The prevalence of bacteremia in infants less than 12 months of age with a UTI is about 4% and as high as 17% in infants less than 2 months of age. 16. 17. Children 2 years of age and older. Older children are more able to voluntarily submit a clean, card-voided urine specimen for analysis, making the need for catheterization or bag collection usually. Table 3. Sensitivity and specificity of components on the urinalysis, alone and in combination. Parameter leukocyte esterase test. Sensitivity range percent 836794. Specificity range percent 786492. Nitrite test 53158298901000. Leukocyte esterase or nitrite test. Positive findings 9390 172 5891. Microscopy. White blood cells 7332 181 45 98. Microscopy. Bacteria 81 16 99 83 11 100.
Zero. Leukocyte esterase test, nitrite test, or microscopy. Positive. Findings 99.8, 99 to 170, 60 to 92. From the AAP Urinary Tract Infection Guidelines.
What up, though? It's Big Snoop D.O. 6, Volume 39, no. 1 January 2018, 7. Downloaded from http://Pets and Review, Publications, / by 967986 on January 30, 2019. Unnecessary. A clean, catch midstream void technique is recommended. 18. Urinalysis and culture results should be interpreted similarly and carefully as in infants. When interpreting the urinalysis results with clean, card-voided samples, clinicians should consider the number of squamous epithelial cells in microscopy. Squamous epithelial cells are predictive of a poor urine sample, and thus a poor performance of the urinalysis, because these cells suggest local genital skin contamination. 19. Basis of strong research evidence. Clinicians treating young children with fever without an apparent source should include UTI as part of the differential diagnosis. Clinicians should evaluate risk factors for UTI, including age, race, temperature, fever duration, and, in male patients, circumcision status. 2. On the basis of strong research evidence, young children with symptoms who are not low risk for UTI should undergo urinalysis. The urine specimen for urinalysis can be obtained via either bag or catheterization. Urine specimens obtained from bags can be helpful to rule out UTI if the results of the urinalysis are normal. However, if the urinalysis from the bag specimen has evidence of inflammation, catheterization is necessary for culture and repeat urinalysis. A culture should not be performed on a bag specimen. 3. On the basis of some research evidence, as well as consensus, the diagnosis of UTI should include clinical symptoms, urinalysis with evidence of inflammation, leukocyte esterase, and or at least 5 WBCs per high power field, and culture results of at least 50,000 CFU/ml of a typical uropathogen. 4. On the basis of strong research evidence, the choice of antibiotic therapy should take into account local susceptibility data, cost of the antibiotic, and patient compliance issues. Typical good choices, depending on local susceptibility, include cefixime and trimethoprim, sulfamethoxazole. Trimethoprim sulfamethoxazole should not be used in infants less than 2 months of age. 5. On the basis of some research evidence, as well as consensus, young children